Wow. Thank you so much for that kind introduction. It's such an honor to be with all of you today. I want to start out by first talking a little bit about some of the amazing successes that we've had in the medical field. So there are about 4,000 FDA-approved drugs that our medical system has developed over these years, which is just incredible. Those 4,000 drugs are approved for about 4,000 diseases. The average drug is approved for between one to two diseases, and the average disease that has an approved drug has about 1 to 2 drugs approved for it. So this is really pretty incredible. However, there are still another 14,000 human diseases that don't have a single approved therapy. Now, most of these are rare diseases that affect small populations, but it's still a huge number of diseases without any treatments. Of course, within our system, we spend lots of resources, unfortunately not as much as we should be spending, but we spend a lot of resources on new drug development, which is critical. But we spend very limited resources on drug repurposing, taking those 4,000 approved drugs and trying to find as many possible uses as we can for those medicines. Now, the reason that drug repurposing, I believe, is an incredible life-saving opportunity is that many diseases may appear very different. So I'll give you a few examples, but they may have the same underlying problem. So many of you are aware that Viagra, for example, was repurposed from heart disease to its very well-known use. But you may not know that it's also been repurposed for a rare pediatric lung disease called pulmonary arterial hypertension. So kids that were dying in their teenage years can now live full lives on Viagra. And thalidomide, I'm sure many of you all are well aware of the horrible birth defects that thalidomide caused. Thalidomide is now FDA approved for leprosy and the cancer multiple myeloma. And now this is an example where myeloma and leprosy could not be more different, but they share the same underlying problem or mechanism in the body and can therefore be treated with the same drug. So in many cases, you'll have the same drug that can hit multiple diseases through the same shared mechanism. In other cases, the same drug can have multiple targets and, of course, be effective across multiple diseases. And, of course, there's also examples where the same disease has multiple targets that could be hit with different drugs. So the reason that repurposing means so much to me is that it's very personal. Repurposing a drug is what ended up saving my life, but maybe I'll go back to 2010, just down the street at the University of Pennsylvania. I was a third-year medical student when out of nowhere I became critically ill. So this is a picture of me in the ICU with all of my organs shutting down. A couple weeks before that, when I was first admitted to the hospital, I got some blood work done, and my doctors came in the room and said, "David, your liver, your kidneys, your bone marrow, your heart, and your lungs, they're all shutting down, and we have to hospitalize you right away." And so I went from being this healthy med student to being in the ICU. And right around the time that this picture was taken, my dad, my sisters, and my girlfriend, Caitlin, were in the room and began saying their final goodbyes to me. And a priest came in the room and read me my last rites because my doctors were sure that I wouldn't survive. At the time, I was a former college quarterback, as you can see from the picture on the left side of the screen, and a healthy medical student who, as I mentioned before, was hoping to become an oncologist just down the road at the University of Pennsylvania in memory of my mom. She had passed away a few years before when I was in college, and I promised her I would dedicate my life to trying to become a doctor in her memory. And then out of nowhere, I became critically ill with this rare and horrible disease called idiopathic multicentric Castleman disease, where your immune system attacks and shuts down your vital organs for an unknown cause. There are about 5,000 patients diagnosed each year in the U.S. About a third of us die within 5 years of diagnosis, another third die within 10 years of diagnosis. Fortunately, right around the time that I had my last rites read to me, my doctors decided to try a combination of 7 chemotherapies, really in a last-ditch effort to save me. 7 chemotherapies that weren't made for my disease, but amazingly they worked. They saved my life. They stopped this disease in its tracks. And you can see from this picture, I survived, and I've got my dad by my side throughout my whole journey. But those drugs, they didn't just save my life in that one moment. They opened my eyes up to this possibility that maybe there were other drugs out there that could maybe save me. I mean, those 7 chemotherapies, they weren't made for me, but they had saved my life. Maybe there were other drugs that could also save my life. Those drugs also gave me, I think, the worst before and after picture of all time. So I returned to med school at Penn, and over the course of the next few months, I was able to get back into my rotations, and I was hopeful that maybe Castleman's was in my rearview mirror. I was actually put on an experimental drug, an IL-6 blocker, that we hoped would keep my disease in remission. But unfortunately, despite being on that experimental drug, I relapsed. And I relapsed a number of times, and by the fourth time I relapsed, and each time got my life saved with chemotherapy, my doctor explained to me that we were out of options and I was approaching the lifetime limit of these chemotherapies, and that one of these times they weren't going to work and I wasn't going to survive. And I promised my dad, my sisters, and my girlfriend Caitlin that I would dedicate the rest of my life, however long that might be, to trying to find a treatment for me and for other patients like me. And when I made that promise, I was absolutely terrified about what was going to happen to me. I knew I had very little time left, and I remember around that time sitting in bed next to my family and just bawling my eyes out. I was just devastated that I wasn't going to have a family one day with my girlfriend Caitlin. I wasn't going to be able to treat patients in memory of my mom. I wasn't going to be able to discover drugs to treat patients like me. And I had this really clear realization as I was like laying in bed just sobbing, and that was that if I wanted to survive and if I was going to dedicate my life to trying to find a treatment for myself, which is what I promised my family I would do, I would need to find a repurposed drug. I would need to find a drug that was already out there. And the realization was because I didn't have $1 billion in 15 years to create a brand new drug. If I wanted to survive, I would need to find one of those existing drugs, maybe a drug like one of those 7 chemotherapies that could save me, but maybe it could save me more long term. So I got to work. I launched a foundation called the Castleman Disease Collaborative Network to bring together physicians, researchers, and patients from all over the world to come up with a research agenda and then recruit the best researchers to do our work and drive it forward. And I also began conducting laboratory research also just down the street at the University of Pennsylvania. And I actually was collecting blood samples on myself every couple of weeks for about 6 months' time, with the realization that it was likely, I thought that I was going to relapse again, and I thought that if I could collect blood samples, then maybe I could run experiments on those samples if I were to relapse. And I did, in fact, relapse. I had that 5th deadly flare, spent another month in the ICU, and thankfully the chemotherapy saved my life. But what was different now is now I actually had blood samples to work with, and I could actually look at these snapshots of my disease emerging once I got out of the hospital. And so the first few things that became really clear, I ran first a serum proteomics panel and also a cytokine panel to look for what were the cytokines that were changing in the weeks leading up to my relapse. And the first thing I noticed was that there was an increase in a growth factor called vascular endothelial growth factor, or VEGF, which is critical for angiogenesis, but also soluble IL-2 receptor was elevated, and that's a marker of T cell activation. And so we thought maybe we were getting some signal for angiogenesis and T cell activation, and I'd also had PBMCs stored, and so I ran flow cytometry on those PBMCs, and I confirmed there was in fact increased T cell activation. So it wasn't just a serum marker of T cell activation, now I could confirm there was CD4 and CD8 T cell activation. So I began to try to think about, what's a mental model for how these things fit together. The increased cytokine production, like CXCL13, the increased T cell activation, also VEGF production. And we started thinking, should we try bevacizumab, a VEGF inhibitor, or should we try to target these T cells? What can maybe be helpful in my case? But then I went back to that serum data, and we had run something called the somologic SomaScan. So we measured over 1,000 analytes in my serum. And initially we were looking for specific analytes that were up or down, but then we decided to run pathway analyses to see is there some sort of final common pathway that's involved in the T cell activation and the VEGF production. And when we did that, we got a really strong signature for mTOR activation. And so mTOR is a critical regulator of metabolism and also proliferation. It's essential for T cell activation. It's critical for VEGF production. And so we thought to ourselves, maybe VEGF could be that common pathway that's maybe involved in my condition. And this was really exciting for me because, as many of you all are likely familiar, there are a number of already FDA-approved mTOR inhibitors. They were famously discovered on the island of Rapa Nui, but actually I want to show one more piece of data, and that was that I had this signature that maybe mTOR was activated, but it was indirect. And so during my last relapse, I had also asked for one of my lymph nodes to be resected for research purposes, so that way if I were to survive, I could actually do some experiments on that lymph node. And so I went back to that lymph node and I stained it for phospho-S6, which is a really good marker of mTOR activation. So this first lymph node I'm showing here is just a typical reactive lymph node. It's what we repeatedly found when we stained phospho-S6 on normal lymph node tissue, and brown is positive, blue is the counter stain. So you can see in a normal lymph node there's some mTOR activation. And then I stained my lymph node, and I was just blown away by the results. I didn't have to look under the microscope. There was such clear and really hyperactivation of the mTOR signaling pathway. And so we had serum data that pointed us towards it. We had flow cytometry data, and now we had tissue data that was pointing to this increased mTOR activation. So I mentioned the island of Rapa Nui is where a drug called sirolimus or rapamycin was first discovered. It's a potent mTOR inhibitor. Has been around for decades. It was initially developed for organ transplantation, FDA-approved organ transplantation, has been used off-label for a few other conditions. But I actually went down to the NIH, to the clinical center at NIH, and I showed the data to a clinician there. All three data sets we looked through, and I said, what do you think? Should we try an mTOR inhibitor? And he looked at the data and he said, listen, I don't have any better ideas, and let's give it a try. And so he prescribed sirolimus off-label, and it's important as we think about drug repurposing to understand off-label prescribing. So once a drug is FDA approved for one use, any doctor can prescribe that drug for any use where they believe the benefit outweighs the risk. And actually 1/4 of all prescriptions in the US every day are off-label. So doctors are prescribing things off-label all the time, and they're getting reimbursed all the time. If they're inexpensive, they almost always get reimbursed. It's just expensive off-label doesn't. So I began testing sirolimus on myself, and it's now been over 11 years that I've been in remission on this drug that wasn't made for me, but that has been able to help me and also patients all over the world. This is a picture of my wife and our two kids now. I've got a 3-year-old and a 6-year-old, and I just feel so fortunate after nearly dying 5 times in 3 years to be able to have 11 years of remission. Just feels like such a dream, especially when you consider that drug was just down the street at my local pharmacy and we never knew to try it. As we shared earlier, I wrote a book about my journey, Chasing My Cure, which actually we announced on Friday is going to get turned into a film. The producer of Forrest Gump and Devil Wears Prada, Wendy Feinerman, is going to make this into a movie, which is exciting. And we've been able to raise a lot of awareness about this journey. And shortly after finding this drug to save my life, I joined the faculty at Penn, where I launched a center called the Center for Cytokine Storm Treatment and Laboratory, with the goal of continuing to search for additional existing drugs that could be repurposed for horrible inflammatory diseases and cancers. And so over these years, we've advanced 13 additional repurposed treatments for diseases that didn't have existing medicines. We've now saved over 1,000 lives with existing medicines. These are just some of the many patients who are doing well today. A couple patients I want to highlight is Kyla. Kyla was dying actually from Castleman disease. It spent a year in the ICU. Nothing was working, even the drug that worked for me. And we ended up recommending a drug called ruxolitinib that was, it's a JAK inhibitor that was developed for myelodysplastic syndromes, and her doctor reached out, recommended this medicine, and Kyla responded really well. She's now been in remission for over 4 years. Actually, I'll go through this quickly. This is some of the data that led us to try a JAK inhibitor. Basically, we did proteomics analysis, which got this JAK signature. We confirmed it in the lab, and then we recommended it for Kyla, and Kyla started her freshman year of nursing school in September, and she wants to be a nurse, as I mentioned, which is just so incredible with this repurposed drug. Another example I want to share is about Michael. Michael was diagnosed with metastatic angiosarcoma in 2016. And interestingly, in 2013, a researcher had published a paper describing 4 patients with angiosarcoma, and they looked at PD-L1 expression in those patients. And there was increased expression across these patients' tumors. So the link was made in the published literature, but no one had ever taken the step to then say, well, could maybe a PD-1 inhibitor treat patients with angiosarcoma? Again, this is just 4 patients, so so the link wasn't clear. But Michael was diagnosed in 2016. He didn't respond to any chemotherapies, and we did the simplest thing in the world. We did a PubMed search, angiosarcoma treatment, and found this, literally, that's how simple it was. Found this paper that had been published 3 years earlier, and got his tumor tested for PD-L1 expression, got him on a PD-1 inhibitor as the first patient ever with angiosarcoma. He responded beautifully well. This April, so this month is actually 9 years, I need to update my slide, that Michael's been in remission. And what's really important about this is that all of his doctors that saw him and saw how incredibly he responded to this, he had metastatic angiosarcoma, have started treating all their patients with pembrolizumab, and actually, without ever even doing a randomized controlled trial, the improvement is so clear that actually it's been added to NCCN treatment guidelines. So patients all over the U.S. and certainly many around the world are receiving pembrolizumab for their angiosarcoma. And actually, he walked his son down the aisle this past September on his wedding day, over 8 years after he was supposed to die from this disease. So with every one of these patients that we save with an existing drug, all I can think about is how many more life-saving drugs are literally sitting at our pharmacy that could treat more patients, not just in the next decade, but literally tomorrow. I think it's helpful to get a sense for some of the barriers that are in the way for getting these medicines to patients. And so Janet Woodcock, who's an amazing colleague and actually a member of the board for a nonprofit I started called Every Cure, highlights a lot of the time the problems we have in our system, and that's that no one's ever been responsible for making sure that drugs are utilized for all the diseases that they could potentially treat. Drug companies develop drugs for 1, 2, 3, 4 diseases, but the dozens of other diseases they consider, there's no one responsible for taking up the baton and pushing them forward. The biggest problem, of course, is lack of financial incentives. So over 80% of drugs are already generic. So there's multiple manufacturers. Each of the manufacturers make pennies a pill. So you might discover that a generic drug could treat millions of people, and each one of those manufacturers might make thousands of dollars, and the math just doesn't add up. So in the current system, there's no one who's taken responsibility for making sure that drugs are fully utilized. About 3 years ago, I launched a nonprofit called Every Cure that's on a mission to take that responsibility. So we utilize an artificial intelligence platform to look across all drugs and all diseases to find the very best opportunities to repurpose these drugs to save lives. You can think about it as being a little bit like typical drug repurposing, where you start with a single disease like Castleman's and you look for drugs that can maybe be repurposed for it. That's traditional repurposing, and that's, of course, how we found sirolimus for me. Drug companies will start with a drug, and then they'll look across all the diseases, and they'll say, what other diseases might this drug work for? And that's traditional drug repurposing from a pharma context. But we do a combination of the two. So we don't start with a single drug or a single disease. We say, let's start with all diseases and all drugs, and then let's quantify the strength of evidence between every single drug and every single disease, and then we can actually let the data tell us what's the best drug-disease match. So if you go into it where you say, I don't care the name of the disease, and I don't care what the drug is, I just want to help people, and I don't care what the diseases that are affecting those people, I just want to help people, then you can find the best opportunities that are really, it's the equivalent of finding the lowest hanging fruit in the forest. And so how do you do that? Well, there have been incredible breakthroughs that were really foundational based on the work that was done at the NIH. So NCATS built a number of biomedical knowledge graphs which really synthesize and bring together evidence from all over the world. I've spoken to Chris Austin about this. He wasn't sure exactly what they were going to be useful for, but he figured if we can get all the data in one place, they could be useful. And this is just an incredible example of where NIH put tens of millions of dollars into organizing data that has just been so transformative. And so these amazing biomedical knowledge graphs serve as the ultimate ingredients for these machine learning algorithms. And so we train algorithms on knowledge graphs and patterns of known treatments. So we know that sirolimus is effective for organ transplant rejection. We can train algorithms on those known treatment relationships, and then we unleash the algorithms on the rest of the graph and say, if we know that these drugs treat these diseases, now quantify the likelihood of every other drug to be able to treat every single other disease. And you get a score from 0 to 1 for every drug versus every disease, which serves as a really great starting point for us humans and medical scientists to then go to the top of the list and say, which drug disease pairs look most promising? And so the way that it works for Every Cure is that we use these knowledge graphs. We also turn to organizations to donate data to us, and actually also turn to physicians and scientists to share with us their repurposing ideas. You can go to everycure.org/ideas and tell us about a drug that you think might be useful in a new disease area. And we use all this information to quantify the likelihood of every drug to treat every disease. There's 4,000 approved drugs, 18,000 diseases, so there's about 75 million drug disease combinations. When we first ran the algorithm 2 years ago, it took us 100 days to quantify the likelihood of every drug to treat every disease using the world's knowledge. Now we run it in about 17 hours, which means that every month we're iterating over and over and over again on the best algorithms using the best approaches. So once we have these scores, we use them internally for our medical team to pick out the best opportunities, but by April of next year, we'll be sharing these publicly with the world. But we use these scores to actually pick out which of these drug disease matches, leucovorin for autism, lidocaine for breast cancer, whatever it might be, which of those require more work in the laboratory, which ones require clinical trials, and which ones are we ready actually to get the word out about them. And of course, it's always with patient impact in mind. It's how can we get these drugs all the way to reach as many patients as possible. Quickly, I'll mention, we like to categorize these treatments into what we call archetypes. So the first one is what we call a frontier explorer, and that's like when we discovered sirolimus for me. There was mechanistic information that was available, but we really had never used it in a human, and there was some more lab work still to be done. Those are really exciting, and artificial intelligence is able to help us identify some of these frontier explorers. There's also what we call clinical gems, where the mechanism is clear, but we need to do more clinical work. We need a clinical trial to really prove that that drug actually works. And finally, we were not expecting to find what we call unsung heroes, but an unsung hero is an example where the medical community has actually already done the work to prove that the drug works, but there's some barrier in the way of patients receiving it. Francis talks often about some amazing drugs, cures for Hep C, that aren't actually reaching all the patients out there. Just because the drug works doesn't mean that people are going to get the drug. And us in medicine and science, we often think getting it approved is the finish line. Well, the finish line is not getting it approved. The finish line is getting it into people. And so these unsung heroes are actually examples where people have done the work to prove that a drug is effective in a new disease area, but maybe that drug is cheap and old and generic, and so there's no one in the whole system that's involved in pushing that forward. I mentioned we ran the algorithm the first time ever a couple years ago. We used the initial results of the first run ever to treat a patient who was getting ready to be transferred to hospice care. He has Castleman disease, the disease that I have, and he was getting ready to be transferred to hospice. Nothing was working, and we just got these results back from the algorithm. And we were surprised to see a TNF inhibitor, adalimumab, as the #1 treatment on our to come back for Castleman disease. TNF inhibition had never been used before for Castleman's, but there was an interesting rationale within the data set. And in parallel, we'd actually been running laboratory experiments, both proteomics data, and then also we had some in vitro stimulation experiments. We were stimulating T cells with anti-CD3, anti-CD28, and we were able to actually describe increased production of TNF by these CD4s. And so taking this all together, we thought maybe this TNF inhibitor could work for this particular patient. So we talked to his doctor in Vancouver, and actually he prescribed adalimumab and responded incredibly well. And so this was just so exciting for us 2 years ago to say the #1 thing that this algorithm predicted that had never been used before for Castleman's was able to save his life. It was such an exciting moment for us. Now, that's an example where our algorithm discovered a new treatment, but as I shared earlier, sometimes our algorithm uncovers treatments that us humans have already discovered, but we've just sort of pushed to the side. And one of them is actually in autism. So what we've learned is that a large portion of children with autism have antibodies against the folate receptor alpha. And because of these autoantibodies, they actually don't get enough folate into their brain. They have a cerebral folate deficiency. And you can give these children all the folate you want, they will get no folate into their brain due to these autoantibodies. But if you give them something called leucovorin, which is a reduced form of folate or folinic acid that was initially developed as a potentiator for 5-FU chemotherapy, if you give that to these children, there have been 3 randomized controlled trials demonstrating improved verbal communication skills in these kids of using this drug that costs about 17 cents a day. Importantly, we started hearing about some of the improvements. This is a patient, Mason, who was nonverbal for 3 years, had very high levels of the blocking antibody in his blood, was given leucovorin, and then within 3 days of starting treatment, said his first word. He said the word more. And as a parent, I've got 2 little kids. My kids ask me for more a lot. and I almost feel like it's my responsibility as a parent to be able to give them more of whatever that thing is. And the idea that Mason could never ask his parents for more for all those years, but now could say more. Now he can say many more words than that. And Ryan, photographed on the right of the screen, he was basically nonverbal for about 5 years. He could say a few words, but mostly it was gibberish. Within 2 weeks of starting Leucovorin, he said his first statement ever to his parents, and it was when his dad was leaving for work. He turned to his dad and he said, "Daddy, I love you." And it was just, when I heard this, his dad told me, he said, "I spent the next 15 minutes bawling my eyes out after my son said," it was the first thing he'd ever told him. And he told him that 2 weeks after being on Leucovorin. And as I mentioned, 3 randomized controlled trials, and still this medicine's not widely used. And I'm just going to close with my last patient I want to share about. His name's Joseph. He was dying from a rare disease called Poem syndrome about a year ago. He was on 4 pressors in the ICU, and I was actually at a UPenn event and got a phone call from his girlfriend saying, "Is there anything you guys can do to help my boyfriend Joseph?" And we found that the top 3 of the top drugs for multiple myeloma, or sorry, for Poem syndrome, were drugs for multiple myeloma, which is actually a very similar disease to Poem syndrome. So we thought it would be very reasonable. Why don't we recommend these 3 myeloma drugs to try to treat Joseph? This is sort of a Hail Mary approach. And Joseph responded really, really well to these 3 drugs. He's doing great right now. I saw him in Vancouver a couple weeks ago. Saw him in Philadelphia a few months ago. He's doing great, and it's just so exciting to think about these medicines that were out there, and if not for these drugs that were made for other conditions, these people wouldn't be here today. So I guess I'm just going to close by saying that we're really looking for the lowest hanging fruit across the forest. So it's not just about saying what's the best drug for Castleman's or the best drug for Poems, but really what are the best matches out there to help people. And when you start doing that, you start finding opportunities that you never would have found otherwise. So we have amazing partners. I mentioned earlier the incredible work the NIH did to build the foundational elements for what we're doing. We also received a $48 million contract from ARPA-H, one of our newest federal agencies in the U.S. government, which all of our fingers and toes are crossed. We'll continue to be able to support this work. And then also receive funding from a project called the Audacious Project put on by TED. So I will close here with my last slide, just say ways that you all can help. The first is that if you have a hypothesis that you think one of the drugs you've worked on in your career could treat another disease that was never pursued, please share it with us. If you want to share your expertise, when we have opportunities like Poem syndrome, we go to our database at everycare.org/experts, and we go to the experts to say, what do you think about this drug for Poem syndrome? So if you want to volunteer to be an expert so we can turn to you for a given disease, please sign up. We also always value data sets that can be donated to us to be included in our knowledge graph. We'd love for you to support any way you can with developing our systems. We're always looking to evaluate these opportunities in clinical trials and laboratory testing. So if there's labs that could potentially partner with us or great trial sites, please don't hesitate to reach out. And then please spread the word about some of these opportunities that we're advancing. A lot of this, as Francis was saying earlier, is about communications and just getting the word out. We're also always looking for really great team members. So if you want to come join our team at EveryCare, we'd love that as well. And just want to close with thanking you all for your time today and the great team we have.
Thank you, David. I have the wonderful responsibility of fielding questions for you, and I hope there are many. There we go. First one, Bill Kalin.
That was spectacular, Bill Kalin from Boston. So my reductionist question is what's activating the mTOR, but we can put that aside. From a systems point of view, obviously when you measure molecular changes in a diseased tissue, some of those changes might be causing the disease. Many of those changes are the consequence of the disease, including some that might actually be adaptive. And so you can quickly get into what I call the blind men and the elephant problem of trying to use the phenotype to choose the therapy. So how do you get around that? I imagine in your case, the temporal information was a bit helpful, but in general, how do you get around that? And what's the denominator here? Like, how often does this approach not work? How successful is it over a large number of patients?
These are great questions, yeah. So in my case, yeah, we worried when I was talking to my colleague at NIH, is the mTOR inhibitor going to be counterproductive? Am I going to go into relapse because there was some sort of, yes, who knows? And so that's a really important point. In terms of how the algorithm thinks about this, these biomedical knowledge graphs have millions of biomedical concepts. So every drug, disease, gene, protein, you can imagine tens of millions of dollars or tens of millions of relationships or edges between each of those nodes. And so built within this knowledge graph are going to be, just like you're talking about, compensatory mechanisms, driver mechanisms. It's basically you're putting it all in one place. And so as a result, I'm certain that there are false positives in there where, we think that an mTOR inhibitor will treat this disease when really that signal there is because it's compensatory. So you don't want to inhibit mTOR. So the important thing is that we use these scores to then have a medical team review through the results and then say, okay, among these, which of these top 1,000 or whatever it is that we look at, which ones do we want to take forward into the laboratory or into clinical trials? And so it's essential you have that human piece, and I think that oftentimes people start talking about artificial intelligence like it's going to just run off on its own, but these are the kinds of things that I think it's really important to have humans reviewing through these so we can actually pick out those opportunities. And then the last one is your question around the denominator, and so we try really hard to not recommend a treatment for a given patient when they reach out to us. The cases that I described were, I would say, sort of exceptions where the first case, Alan has Castleman disease. We just looked at the number. He was going to go on to hospital. Like, this was it for him. Joseph, same sort of thing. We found a result for a related disease, so we felt confident saying, like, let's try this drug. But we're getting a lot of inbounds, but we're really trying not to make too many recommendations, because what I believe is missing in our system is not a group of people that respond one patient at a time. I think what's missing in our system is an entity that looks across all drugs and all diseases to find the great low-hanging fruit opportunities and then does the work to move them forward. So that way, by the time you're sick with that disease, we've got a treatment for you, not that you need to come to us afterwards. So we're really focused on identifying these opportunities and fortunately not doing as many of these one-offs.
Yes. Be brief and state your name and place of...
Joanna Eisenberg, Massachusetts. I have a question, somewhat you answered that, but are you looking for what we call now personalized medicine? We're all different. Can you, based on your research, define what may or may not work because of the differences, not because of similarities?
Gosh, great question. So not right now. Our knowledge graphs are at the unit of the biomedical concept, so the disease. There are certainly subtypes within our knowledge graph, so we can recommend drugs based on subtypes, but that's where us humans have to come in and really design good trials for who are the patients and what are the biomarkers that might lead us to believe it's going to work for one group or another. But right now, no. It does not involve... So sometimes patients will come to us and say, we'll give you, our medical record data and to put it, and we don't have a process to provide personalized recommendations. It's really at the level of the disease. I hope we can go there, though.
Your strategy, which is obviously very impressive, it's very dependent on your model and the predictions that you're making, which you say you're upgrading regularly. What I wonder, do you have a strategy in your mind for how one, over a number of years, could really upgrade the quality of those predictions? Because that could push the number of diseases that you can find things for, even higher than what you've done.
Yeah, it's a great question. So there's a few ways that we think about improving the prediction quality. So one of them, and this is actually what folks at OpenAI and others in AI are doing, and it's actually surprisingly simple, but it's just physician and medical scientist preference. And so providing thumbs up and thumbs down to things that we like at the top and training it on, we really like this drug for this disease, and being able to feed that back in seems simple, but that's unfortunately state of the art for a lot of the ways that we train these models. But much better than that is to be able to do some sort of high throughput laboratory studies. The challenge is you can test all drugs for one disease in one model, and now you've looked at 4,000 out of your 75 million possibilities. And so we can continue to do that as much as possible. I think the proof is somewhat can be in the pudding of our clinical trials, and the idea being that we're a lot better than 10% in terms of our clinical trial success rate, and the more wins we can get, hopefully we can feed that back in enough to where we can train the algorithm. But even still, then now you're talking in the single digits or tens to train on 75 million possibilities. And so I think that all the things I mentioned, plus leaning into some of the newer agent models with artificial intelligence, should hopefully get us better and better.
We have one question on this side, short, please, and then the last one will be in the back.
Okay, thank you. Nicholas Sims-Williams from Cambridge, UK. I'm a humanities person, so forgive me if this is a very stupid question, but I'm just wondering about traditional medicines. I mean, there are traditional medicines which aren't part of modern medicine, which maybe have the tradition of working. Have you discovered in your research that sometimes the active ingredients in some traditional medicines are in fact, turn out to be practically useful in ways which was not previously known?
It's a great question. So we are able to run our algorithm with a total of 100,000 compounds, which includes a lot of these traditional medicines. We almost always run it with just the 4,000 for compute reasons. But one of the challenges is that a lot of these traditional compounds, there's just so much less information, and it's so reliant on the knowledge graph, having knowledge about the drug to really be able to make strong predictions. But you may have seen on the screen, arginine for sickle cell disease is something that's very high up on our priority list. And arginine is a simple amino acid that you could get at your local health food store, and I don't think any of us would have been thinking about it. It's not complex. It's not actually fixing the problem of sickling of cells. It's just opening up the blood vessels more, so that way if there is sickling of cells, you've got bigger highways or bigger pipes to run down. And so sometimes really simple things like that can actually be pretty elegant. And so we're not opposed to alternative and traditional medicines or supplements or vitamins. There's just oftentimes less information.
Judith Resnick, New Haven, Connecticut. First of all, thank you for a moving account. I'm interested in the question about the competition among cancer centers around the United States and the coordination. So it relates actually to the earlier talk about how do people see the stunning utility of sciences at all different levels. Given major cancer centers in many of the places we all work, how are you all networked in some cooperative, I said, hopefully, interaction?
It's a really important question. So through every cure, we're looking across all diseases. And so we haven't focused specifically, though there are a few cancers that are the top of our pipeline, we haven't focused specifically in one group of diseases or another, which is a real challenge. I mean, organizations get really good by getting very good at a particular disease or a particular specialty, and we're agnostic in that way. And so with every one of these opportunities, we're going to need to build, or hopefully not build, turn to existing infrastructure like these cancer center networks to be able to really move things forward. But as of right now, we don't have any established partnerships with cancer centers.